Right, so we talked about all these different systems, and I started a little bit in the last section talking about treatment for different chronic pain syndromes, and different medications are sometimes used. Some people have success with them, some people don't. The pregabalin series, gabapentin, Lyrica, several different brand names are sometimes used for fibromyalgia and for neuropathic pain with mixed success. Surgical treatment, they used to think that they could just get rid of the connection to the peripheral nociceptor that's causing the pain, but of course we know with the top-down pain matrix dysfunction, that is not going to have the effect that we want. Sadly, those central nervous system changes get to keep sending you pain, even if you interrupt those pain-mediating fibers in the dorsal column. So there are also a lot of psychological factors in chronic pain. So people have different expectations, different cognition levels, and different emotional aspects that affect the experience of pain. Anxiety, depression, catastrophizing can all predict reactions to pain and the ability to cope with pain. So when we talk about catastrophizing, it's sort of like somebody says, oh my gosh, I'm never going to get better, I'm going to end up in a wheelchair. And actually, I just heard somebody say that yesterday in the clinic, and I sort of scoff at that idea, but really, if you feel that way, and I don't want to scoff at anybody's feelings, if you feel that you're never going to get better and you're going to have serious consequences, that is going to influence how you cope with the pain. So the amount of pain that somebody expects influences processing in both the medial and lateral pain systems. So if you're expecting more pain, you're going to get more pain. The interesting thing that I see in the clinic with total knee replacements, because I work with a lot of patients with total knee replacements, I get what I call my alumni coming back. The person that had their left knee replaced last year and now they're back again this year or 2 years later to get their right knee replaced. And the vast majority of people tell me that the second one was so much easier. And so I have my unsubstantiated theories as to why this is so, and I always discuss it with people because I think it's interesting. But this is completely unscientific, but here you go. One of the reasons could be that the doctor replaced their worst knee first. So that one was a more involved surgery and they had more pain with it. Another reason, which I think is a big factor, and most of my patients agree with me, is the second time around they know exactly what to expect, and it's a lot easier because there's no big surprises. They know what's coming, and they have a much better and faster recovery the second time around. So the amount of pain they expect influences the processing of that pain. Very interesting. So therapists have to address all 3 Ds of chronic pain: distress, disuse, and disability. Okay, so people are going to be in distress with pain. And a lot of times you'll get people and they cannot talk about anything else except their pain. And until you address that distress, you're probably not going to get anywhere. And then you have to address the disuse factor and the disability factor. So psychologic interventions that we can do, in some of them in physical therapy, can decrease activation of the pain system and also help improve coping skills. So relaxation, breathing, and muscle relaxation, we can certainly teach that in physical therapy. That is an excellent intervention. Biofeedback, yes, we can do that. We can do it either with machines, like we talked about a little bit last quarter, or with other ways of monitoring your system. You can use imagery to help decrease activation of the pain system and improve coping skills. And then cognitive behavioral therapy, that's outside of the realm of physical therapy, but that is another thing that can help with pain coping skills. Placebo-associated improvement is defined as any genuine effect, whether it's psychological or physiological, that is attributable to receiving a substance or undergoing a procedure, but is not due to the inherent powers of that substance or procedure. So if I take a medication and it's a Tic Tac, it's not doesn't really have any effective dosage. If I get genuine effects from it, that's a placebo-associated improvement. It's still an improvement. The improvement is real. It just isn't due to the inherent powers of that substance that I ingested. There was a study done I think it was in 2003, and it may or may not be quoted in the book. I will find a reference for you and put it in the module, but it's they did basically a sham surgery. A lot of people didn't really like it because they didn't like the idea of a sham surgery, but one of the surgeries for a compression fracture in like a thoracic vertebra is a vertebroplasty, where basically they do it radiographically. They you have an X-ray of the person. The radiologist uses a balloon to inflate the collapsed vertebra, and then they basically fill it with cement, body grade cement. But it's a vertebroplasty. So it involves a small incision, the radiographic analysis, the sort of reinflating of the collapsed vertebra, and then shoring it up with a cement. So in the sham surgery, they took them into the radiation suite, or the radiology suite. They did a small incision. They sprayed the smell of the cement that they use, and then they closed up the incision, and the person went out of surgery. So they didn't actually do anything to the vertebra, and a huge percentage of people responded with less pain. So that was a placebo-associated improvement. So they had that procedure, they underwent the procedure, but the procedure didn't really do anything, but they did have actual improvement. So pain is an amazing, complex thing that can be affected in a lot of ways. Psychological approaches to dealing with chronic pain include providing positive yet honest communication about the therapy. So just saying, like, yes, this might help you a little bit. It might not get rid of all your pain, but be positive, be honest. Providing encouragement and education. So our chronic pain education program that we do in our clinic is largely about this, providing encouragement, education, and tools for that person to help manage their pain. And developing trust, compassion, and empathy, and understanding the person as an individual. Creating rituals that provide meaning and expectancy for the person. So one of the things that I always talk about with people in our chronic pain education program, I say, what did you do today that you enjoyed? Do something every day that you enjoy. Create that ritual that provides meaning and expectancy. Plan something for tomorrow that you're going to look forward to. Pain can take over your life, and if you don't let it take over your life, you can get a lot more out of it. So I think it's so important as therapists for us to absolutely respect that no matter what the cause, our patient's pain is real, and they are really experiencing it. And we need to have trust, compassion, and empathy for our patients. We need to make sure we're doing our best to provide support and therapy that's going to help them get through this. A lot of times, though, that having been said, there can be conflicts between patient goals and provider goals. People with chronic pain often want healthcare providers to acknowledge them as individuals and to have their pain recognized as biologically based. So many people, they say, if I could just see it on an MRI or just see it on an X-ray or just have a test that tells me it's biologically real, it would make me feel a lot better. People really want that. So they want people to acknowledge them and their pain. And, I think that's valid. It's absolutely valid. But healthcare providers are frequently more concerned with diagnosis and treatment than providing the biological explanation for chronic pain. So an important factor in achieving a positive patient and physical therapist interaction is the therapist's ability to explain treatment recommendations in a way that's consistent with the patient's existing beliefs about his or her chronic pain. So part of our chronic pain education program is teaching people about how their pain systems work and what central sensitivity is and how it can affect them. So in other words, we're trying to affect the patient's beliefs about their chronic pain. We're trying to sell them the idea that that even though you can't see it on an MRI, there are other things going on in their nervous system that can cause and perpetuate pain. So really though, I think acknowledging your patient and working with chronic pain sufferers is a very challenging area of therapy. I've had people sit and cry through a whole session. It can suck the energy right out of you if you have 3 people like that in a day. Luckily, mostly I don't, but it just, you have to really put on your empathy and compassion hat and realize that these people are truly suffering, regardless of the source of their pain.